Hey everybody, it's Dr. Wood, and today we're going to be talking about our blood and circulatory system disorders. And so, again, a lot of common reasons why patients are going to be presenting for issues relating to the cardiovascular system, chest pain being a huge one. You always want to make sure you rule out things like myocardial infarction for those patients, but they can also be presenting with weakness and dyspnea, palpitations, anything like this, are all big reasons that could be related back to the cardiovascular system. And so, along with that, a lot of common side effects you're going to see with these medications basically includes things like orthostatic hypotension, right? This is basically where, as a person goes from sitting to, say, for instance, standing, you'll then find that their blood pressure is not able to sort of keep up, and they can end up developing hypotension, which can lead to dizziness and falls and things like that. Urinary frequency is going to be a big one. You can see with a lot of diuretics, and then unfortunately, especially for older male patients, impotence is a pretty common thing you're going to see there. Even though the drugs may work very well for them in terms of controlling things like blood pressure, you may find that the erectile dysfunction seen from that is just intolerable, and they'll say, I'm just not going to take the medication there. Okay? So here's some other common ones you're going to find, along with all the other side effects that are unique to individual drugs. So starting off with angina pectoris, some people say angina, I say angina, but basically this is going to be a disbalance between O2 supply and O2 demand of the heart, right? Basically, we're not providing enough oxygen to the heart itself, maybe due to things like atherosclerosis or narrowing of the coronary vessels, or maybe we're demanding too much. And so this is related usually to things like exercise or some sort of physical exertion is occurring here. And so basically, when you have that, ischemia starts to develop in the heart, and that's what causes the chest pain. And so you can find there's several types. There's some, for instance, the most common one is going to be exertional angina, which is usually triggered by physical stress, and this is usually related to coronary heart disease. And then you have types like variant or vasospastic angina, and that can be seen in younger patients where basically the vessels themselves will spasm and can lead to decrease in oxygen-rich blood getting delivered to the myocardial tissue, leading to angina. Basically, our big goal here is to try to reduce the number and severity of attacks and hopefully prevent progression to full-on MI for those patients there. So a couple classes of drugs we're going to see being used, and again, the textbook is going to be a good resource here to go into the individual drugs because there's so many, we really don't have time to talk about them all here. Usually for my PA classes, I mean, this is like several weeks worth of material just getting through all the cardiovascular stuff, usually about a month or so. So you can look at the individual drugs and that'll be useful for quizzes and things like that. One of the big classes, though, we'll find here used for angina is going to be our nitrates. And so the biggest one used here is going to be nitroglycerin. This is oftentimes abbreviated as NTG. And basically what it does is it dilates the coronary vessels to give more oxygen-rich blood to the heart there, and can be really useful to help relieve intense anginal attacks. And so you can kind of think about sublingual or buccal nitroglycerin as kind of being like a fast-acting medication for quick symptom relief, kind of like how albuterol is for asthma. And so not only that, but we can also use long-acting forms in order to try to prevent attacks from occurring as well. So like nitroglycerin ointments or patches, things like that. Other drugs we may use include things like beta blockers and then calcium channel blockers. These all actually slow down heart rate and can help to decrease the amount of oxygen demanded by the heart, such that it helps to give them more time while they can exert themselves before they become symptomatic. So again, nitroglycerin dealing more with O2 supply by supplying more oxygen-rich blood to the heart, and the beta blockers and calcium channel blockers dealing more with O2 demand. So here's an example of what nitroglycerin tablets would look like. You see here, basically this would be placed underneath the tongue where it can then absorb through the oral mucosa. You don't want to use this orally. You don't want to have them swallow it because they can end up losing that bioavailability there. And so basically this is a big thing here is you want to make sure that patients, if one dose of the drug does not relieve their symptoms, they need to call 911. Back in the day, we used to say, hey, we'll take a pill every 5 minutes, and after 3 doses, if it doesn't work, then go ahead and call 911. We realize it's a problem now because all that time they're having angina, that means their heart is becoming ischemic. It's not getting oxygen. So in the cases there, we said, well, time is tissue here, and so if one dose doesn't do the trick, then you need to call 911, and then you still keep taking every 5 minutes or so until 911 gets there and they can provide more definitive care. Now, it's really important to make sure that they label when they open up the bottle. Nitroglycerin is a pretty unstable molecule, and so you want to make sure they know when they opened it so that way they can replace it usually every 3 to 6 months or so. If they are using patches or long-acting formulations, you want to make sure they don't use it for more than 12 hours out of the day. That's mainly because the drug loses efficacy if you use it 24/7. And so normally we'll have them use it during when they're most active. So if it's someone who has a day job and they're most active during daytime, then we'll go ahead and have them take it during the daytime, so that way it's most effective. And then at night when they're sleeping, they don't really have to worry about exerting themselves too much there. It's really important not to discontinue long-acting formulations cold turkey, because that can actually cause rebound angina and can actually induce an MI in some cases there. Now, moving into congestive heart failure or chronic heart failure, depending on how you want to call it. Basically, this is related back to reduced cardiac output. Basically, the left ventricle is not going to be able to work quite so well anymore. And so one of the things you'll see there, the left ventricle is going to be losing some of the contractility that it has. And what you're going to find is that their ejection fraction is going to go down. The EF usually is greater than 50%, is going to get less than that. So usually like less than 45% or so is considered to be CHF. And so that normally happens as a result of cardiovascular disease, normally like hypertension, previous myocardial infarctions and things like that cause the left ventricle to become thick and hypertrophic, and it's just not very efficient anymore. And so what can happen is they end up developing a lot of accumulation of fluids because they can't pump it around effectively. So they can have things like peripheral edema, which is going to be fluid developing in the tissues there. And then this can be pulmonary edema if it's going to be in the lungs there. And so basically that fluid is building up in there as a result of the fact that you're not able to pump it around and get rid of it through the kidneys effectively there. And so this can be a big problem. This can lead to a lot of hospitalizations and death in some cases for patients who cannot get this under control. And so there's a lot of different medications we'll use for them in order to help control this. And so we have things like ACE inhibitors, things like ramipril and lisinopril. This is really good because it prevents what they call left ventricular remodeling, which can actually help to extend life in some cases there. Things like beta blockers help to reduce strain on the heart and help to kind of keep the ventricle working better for longer. And then this is probably one of the most important ones in terms of symptoms. It's going to be your diuretics, meaning they're drugs that help you to urinate more. And so you're going to find that Lasix or furosemide is the most common one they take there. And so one of the things we'll have patients do with CHF is they will monitor their weight daily, and if they see that that's starting to go up, say by a few pounds every day, that usually means they are building up fluid, and they'll start taking their Lasix here and help to get rid of that. And we'll also have a cardiac glycoside. This group contains the one drug called digoxin here. And so this one is used sometimes to help reduce symptoms for long-term control. However, no, it has a narrow therapeutic index, which means you have to use blood level monitoring for that. It's called therapeutic drug monitoring, where you can actually measure blood levels of the drug and it can adjust it, mainly because it has so many side effects and so many interactions that can come about from its use. Now, oftentimes patients with CHF are going to require multiple different medications in order to get things under control. So they're typically on a diuretic for the fluid control. They're on an ACE inhibitor to keep their blood pressure in check and to help make sure the left ventricle stays better for longer. And the whole goal here is to make sure that you are trying to preserve as much function as you can, because otherwise you're trying to prevent the need for eventual heart transplant, which a lot of these patients don't end up getting, unfortunately. Now, in terms of treatment of dysrhythmias, this is basically where a patient is having a deviation from a normal heart rhythm. So if you hear about normal sinus rhythm, that means it's a normal rhythm for that patient there where things are beating just like it should. When you have a deviation from that, it's what's called a dysrhythmia. And basically is due to alteration of the electrical impulses, right? Because normal electrophysiology, you'll have an action potential start in the atria that travels through the ventricles that causes the contraction of the heart in a very sort of concerted manner that allows for efficient pumping of that blood there. And so you're going to find there's a lot of reasons why patients develop dysrhythmias. It could be related to drug therapy, it could be frequently due to heart disease and electrolyte disturbances. Even things like thyroid disorders can actually cause this as well. And so you can find in some cases it may be sort of a minor inconvenience, like something like AFib is sometimes going to be something where patients are not that symptomatic from it, or in the case of something like a ventricular arrhythmia, things like VTAC or VFib, that is absolutely not compatible with life, and they can die from that very quickly. And so it's important to understand that any antiarrhythmic drug potentially can cause an arrhythmia in and of itself, just like any anti-cancer drug can cause cancer in and of itself. But we basically will break them down into 4 different classifications here based on where they actually work in the heart. So for instance, class 1 binds to sodium channels and prevents basically the sodium from coming into the cell to cause the action potential, and will slow down this impulse conduction. Okay, we'll have class 2 antiarrhythmics. These are going to be your beta blockers. And then we'll have class 3 that actually works on potassium, so keep potassium efflux from occurring here, which also kind of prolongs the potential contraction duration. And we'll have class 4, which are going to be your calcium channel blockers. And so there's 2 specifically that fit into this category that we'll use as an antiarrhythmic, and that includes verapamil and then diltiazem. These are the 2 that have specific effects on the heart. All the other ones, things like amlodipine and felodipine, only work on the blood vessels. And so basically what they're going to either do is they will work on correcting, or they will compensate for the altered rhythm. And so they can either convert the patient back into normal sinus rhythm, or sort of just help to kind of control things such a way the arrhythmia is not going to be very symptomatic for them. So for instance, if a patient has a treatment of a supraventricular tachycardia, meaning it's happening above the ventricle, well, we can give something that actually blocks that conduction at the AV node, right? So if you imagine looking at the 4 vessels of the heart, so you have your 2 atria here, and of course this is not physiologically accurate. Normally you have your SA node here, and then your AV node here, and that sends the signals down. Well, if I can use something that blocks this and slows it down, that can help the ventricles to still kind of pump normally in those points there. If you have a ventricular dysrhythmia, it's really important that you eliminate that abnormal rhythm altogether. Otherwise, the patient is going to have a rhythm that's not really compatible with life, and they can die from that. So this is what we see a lot in the ERs. And just remember that antiarrhythmic drugs can either worsen existing conditions, or they may generate new rhythm disorders all on their own. So it's really kind of a trial and error kind of thing to see what works well for the patient. So just to give you some examples of different class agents here. So for instance, class 1 medications, quinidine is a good example of this one. Good for working on ventricular dysrhythmias, right, by blocking sodium channels. You'll find that class 2 and class 4 medications here, so your beta blockers and your calcium channel blockers, will actually work very similar together, and they really work well on supraventricular, or things that are happening above the ventricle. So things like atrial arrhythmias are treated very easily or very well with something like a beta blocker or calcium channel blocker. Something like propranolol is a good example of a beta blocker. Class 3 medications there, this includes something like amiodarone. These are going to be sort of our go-to ventricular agents here, because they're blocking potassium channels, and they kind of help to reset the heart a little bit. And so if you're having, say for instance, a dysrhythmia causing a cardiac arrest, oftentimes we'll use amiodarone in conjunction with things like electricity to try to get the heart back into a normal sinus rhythm. So talking about hypertension, there's several different stages of hypertension we can talk about. Pre-hypertension is usually, if you think about a normal blood pressure as being 120 over 80 millimeters of mercury, which is our normal units here we measure this with. And again, the top number here is going to be your systolic number, and then the bottom number here is going to be your diastolic. This normal blood pressure. Anything below this is considered normal. Patients that pre-hypertension are in that range of 120 to 139 systolic and 80 to 89 diastolic. And the higher the blood pressure goes, you're going to find the more at risk you are for things like chronic cardiovascular disease. And so we'll consider anything to be hypertensive to be above 140 over 90 there. And oftentimes this is idiopathic, meaning there's not really an apparent cause. Oftentimes it can be related to high salt diets, genetics, medications. There's a lot of reasons why patients are hypertensive, and they call it the silent killer because a lot of times patients are hypertensive for a long period of time and they never know about it. It's not until you get up into something like 200 systolic where you start to develop end organ damage, where you can actually tell and feel the patient's hypertensive. So that's why they call it the silent killer. So there's a lot of categories here of medications that we can use. And again, the book is going to be helpful to look through and see all the ones we can talk about in more detail. But things like diuretics, things like your thiazide diuretics are big here. So HCTZ or hydrochlorothiazide is a really good thiazide diuretic for blood pressure management. Things like adrenergic inhibiting agents, things like alpha blockers. We have things like centrally acting drugs like clotting, which help to decrease adrenergic activity from the brain down. Things like ACE inhibitors, which we talked about with CHF being really good there. Angiotensin II receptor blockers, vasodilators, all different ways that these drugs can work together in order to help get the blood pressure under control for your patient. They all have their good points and they all have their drawbacks. And so it's important to consider patients' other drugs that they take, other disease states they have, because you can find that, for instance, like ACE inhibitors, like patients with diabetes, this is actually really good for them to be on because this is going to be what we call nephroprotective, meaning it's going to help to protect the kidneys and help keep them functioning for longer, because kidney disease is a common thing you're going to see in patients with diabetes mellitus, right? So ACE inhibitors are a really good one for them. So a lot of different agents here, a lot of different categories, and again, they all have their pluses and minuses. One thing to note, because a lot of patients will start off with a diuretic like HCTZ, you may develop dry mouth as a result of that diuresis, and so it's good to sip water or chew gum to help relieve that. And if you're taking it twice daily, we recommend using it around 8 a.m. and 2 p.m. The reason for this is if you take it later than that, there's a lot of nocturnal awakenings, and patients have to get up in the middle of the night and go and urinate a bunch. That may not be very conducive to a good night's sleep for them. Note as well, postural hypotension and resultant falls and confusion can be pretty common with these drugs, especially in elderly patients. So you do want to watch out for that. And then also make sure to monitor their weight. Just like we talked about the CHF, the diuretics, if their weight's going up, then they may be holding on to too much fluid there. Very frequently, though, patients will benefit most from just changes in lifestyle here. So they can get more exercise, if they can get their diet under control. They may not even need medications altogether. So this is a really important thing to harp on as well, but will frequently fail in a lot of patients. And so what we'll do is, for instance, put them on a thiazide diuretic, and this will help to get the blood pressure under control by getting the blood volume down and lowering the arterial resistance, and that way overall the pressure goes down for those patients there. Thiazides like HCTZ are typically a first stop for many patients, mainly because it's very well tolerated and it's pretty effective what it does. So as I mentioned in the book, you can check out the different classes here by looking at these tables. It's important to know how these different drugs are going to be working and sort of the common side effects, things you might run into with them. And again, many of these might be lifelong medications for the patients, mainly because they're going to be hypertensive the rest of their life potentially, and so they may need to be on these drugs and help manage that and prevent outcomes like myocardial infarctions. Again, you'll frequently find the ACE inhibitors and things like thiazide diuretics specifically are going to be recommended first line for initial treatment of hypertension, and then sometimes you have to use combinations. So for instance, you can use something like say lisinopril plus HCTZ, and this is a thiazide diuretic plus an ACE inhibitor, and you get way better actions out of both of these because they synergistically make each other work better there. And again, just know that how these drugs are going to be working together. Typically, we like to use different classes together in order to make sure that we get some synergy there out of those combinations. There's also what we call peripheral vascular disease. This is usually related to poor circulation in the extremities, especially the lower extremities. That can lead to things like intermittent claudication, where they have pain on exertion, like when they're walking around. Their calves will start to cramp up and become very painful. It's called intermittent claudication. And frequently is caused by things like atherosclerosis and hyperlipidemia. And again, a lot of these things can be precursors to developing cardiovascular disease and MI. And so frequently we'll treat this with hemorrheologic agents, meaning rheologic means how well how things flow, and so these are things that help blood flow a little bit better there. And so things like hydroxychloroquine or Plaquenil can be used in order to help make sure that the blood flows better and does not get clogged up in the peripheral vasculature, essentially. And that was what caused a lot of those symptoms. Now, in terms of getting cholesterol under control, this is really important for most patients who are at risk for cardiovascular disease. These are called anti-lipemic agents, and they're going to be able to help get cholesterol and triglycerides under control here. And we know that we want these to be under control because if you have too much cholesterol around, that leads to fatty deposits in the arterial linings. And so if you imagine, looking at a blood vessel, and you see here that has a nice wide diameter, but as patients get older and say they have high cholesterol, you end up seeing they develop these plaques here that can lower and lower the amount of blood flow that can come through, right? So this is all just atherosclerosis, and very low flow coming through here, meaning you can develop things like MI if this is one of your coronary vessels, right? So anyway, so we know we have different types of cholesterol. HDL is what we consider to be the good cholesterol. We want this to be higher in patients because it's actually protective. It actually carries other cholesterol to the liver where it can be processed. And LDL is our bad cholesterol. This is what we actually want to get rid of as best we can. Okay. Now again, you always want to try diet and lifestyle changes before using anti-lipemics, so just be aware of that. However, most patients may have a genetic predisposition to hyperlipidemia, so this may not always be the most effective. Now, basically what you're going to find is that, as I mentioned, diet modifications is a huge thing to help reduce LDL, but our statin drugs are going to be the most effective drugs specifically for lowering LDL, and basically this is going to be the most common set of drugs people will be on. So things like rosuvastatin. You can always tell a statin drug because they'll have statin at the end of the name there, or say for instance atorvastatin are probably the most common ones you're going to run into out there. And so these are very good drugs to help get the LDL under control and hopefully prevent patients from developing cardiovascular disease later on. Okay. In terms of coagulation, we know that in some cases blood needs to clot in order to help heal a damaged vessel and prevent bleeding from occurring. And so in some cases, though, we want to prevent this from happening because sometimes you get abnormal clots that should not be there. So for instance, if you have a patient who's been on a long flight and they've been sitting around for several hours, they can develop a clot in the leg, right? Which can lead to things like DVT. Or if they clot from the leg, from a deep vein thrombosis leads up into the lungs, then you end up developing what we call pulmonary embolism, or PE. And so these can be life-threatening in some cases there, and you have to give drugs to prevent that clotting from occurring. And so we have kind of a couple of different things here. We have things like antiplatelet drugs. These are ones that are working expressly to prevent platelets from clotting together, and like aspirin's a good example of an antiplatelet drug we've already talked about. In some cases, we use thrombolytics, which actually work to directly dissolve clots that have already formed. So if you ever hear of a drug called TPA, this is what that's referring to, is it's a clot-busting medication there. And then sometimes, like in surgery, we'll use things like hemostatic agents that are either gelatin or cellulose-based that actually help to soak up extra blood and fluids. Now, in terms of common anticoagulants you run into, heparin is actually a product that our body naturally produces, but we can give exogenous forms to help supplement that. And so these are always going to be given parenterally. And if you ever hear about unfractionated heparin and then low molecular weight heparin, basically they're varieties of the same thing, where heparin itself is a very long molecule, and if you chop it up, you end up getting these low molecular weight heparin. So enoxaparin is a very common one you'll see there being used in the hospital. Because these have to be given parenterally, either IM, sub-Q, or IV, these are not good for at-home use, for chronic use, and this is where things like our oral anticoagulants come into play. And warfarin was one that was used for a really long period of time, using for decades and decades, and so we have a lot of experience with it, but there's a lot of drawbacks. Like for one, it's very diet dependent, meaning if a patient had altering or variable levels of vitamin K being taken in, you typically find that it could mess up their blood levels pretty significantly and can lead to either too much of a risk for bleeding or too little risk, or more likely they develop a clot. And so they had to measure their PT-INR really frequently. They'd have to come in sometimes, every week for a while in order to get their INR into range there. And so nowadays we actually have some newer oral anticoagulant agents, or the NOACs, and this includes things like rivaroxaban and apixaban. And these are really starting to steal the show a little bit because they don't require nearly as much monitoring, and they're a lot easier to use. So you may see more patients being put on this than you do warfarin. And then finally, we have a group of drugs that actually stimulate production of some of your blood cells, including things like hematopoietics, which basically stimulate production of things like white blood cells. And this is good for patients who may be taking drugs for cancer that are depressing or getting rid of their own white blood cells. This can be very useful to help them kind of recover there. And then we'll have drugs called erythropoietics, where basically they actually stimulate the formation of new red blood cells. And this is used a lot for patients who maybe have either chronic disease that leads them to be anemic, or if they're not getting enough, say for instance, they have bad kidneys and they can't produce erythropoietin. This is a good way to replace that, and can be useful because it helps to prevent blood transfusions, because if the patient can produce their own blood, then they don't need to get a transfusion from someone else. So that can be useful. And these are also administered parenterally because they are usually proteins, and it doesn't go well in terms of oral bioavailability due to the fact that your GI tract just naturally breaks down those proteins. Anyway, so again, this is a quick coverage for a big section there. If you have any questions, though, please let me know. And the book is going to be very helpful to kind of delineate between those different classifications that we talked about. But again, this is meant to just give you a kind of a brief introduction. But if you have any questions, please let me know. I'll talk to you soon. Thanks.